most important single thing is that anybody who is diagnosed as HIV positive today should live a normal lifespan.
Right.
With the right therapy. So that means, one, that people must know their HIV status, that's very important. Two, they must then have access to therapy, and therapies become very easy. As soon as you are positive from the START study, which is one of the new studies, you need treatment, so from straight away. So there's no need for lots of laboratory monitoring. Everybody who's HIV positive needs to be on treatment for life. One of the most impressive things at this conference is the enormous range of treatments which are available, made by the generic companies in India, which are relatively cheap. Now, one of the problems with HIV is, of course, that it affects disproportionately the people with no money at all, who can't afford even these moderately priced medicines, and they need government and international support to obtain treatment. But it would be a disgrace if people are dying because of these medicines, which are now very cheap, were not made available to them. Now, I think that one of the things that we understand from different areas of the world is that we can largely de-medicalise this, that probably the best people to give most of the treatments are other people who are HIV infected. They are much better at explaining why it's so important to take treatment, and as personal examples of people who are better, it is often a good role model to ensure that treatment is taken. So we need to de-medicalise the care. It is crazy that the doctors maintain control and say you must come every month and have a blood test, I will only give you a month's medicine, when many people can't afford to get there. So we should be giving 6 months of medicine, and we should be using peer people to take the medicine to the local communities, rather than expecting the communities to travel hundreds of miles to see the doctor, who is often late and doesn't bother to talk to them. So I think we need to change the model, and the WHO are doing very good work, because we now have so many options available that you take, for example, in crude terms, a white pill until you fall ill again, and actually if you take the white pill regularly you will never fall ill, but say for 2 months you can't take it for some reason, or you run out of supplies, then there will be a pink pill available, and you take that forever, and then you can't take that, then the options are either to die, or there may be a green pill to take as well. So medicine is becoming very simple, and we need to probably monitor people much less. Now, of course, the reality is that monitoring is also becoming both easier and cheaper, and so now there are CD4 machines, which we see again in the exhibition hall here, which are really very cheap, and viral load perhaps down to as little as $10, 100 rupees, 200 rupees, are really feasible. So how much monitoring you need, I think, is arguable if you can get the group of people to take the treatment. So those are very important developments. I think another very important development is the realization that if you are taking the treatment and there is no virus in your bloodstream, i.e. you're what we call undetectable, then you will not infect your sexual partners. That's the simple and true message. Now all doctors get worried and they make caveats, and you mustn't take drugs that interfere, and you mustn't have diarrhea, and I agree with all those, but that is the truth. If you are undetectable, you will not transmit HIV. Now, you may need to wear a condom to prevent other sexually transmitted diseases, but for HIV, you will not transmit it if you are undetectable. And so really the epidemic should slow down. One of the modelling problems is that this ability to treat quite a lot of people, and that the people that you treat don't transmit the disease, that has not resulted in a reduction in the epidemic. And the two issues there are still a lot of people who don't know their status, who will transmit it to other people, and that's probably the most important thing for continuing transmission. And also that starting really early is probably very important, because the most risky period for transmitting to others is those few months after seroconversion. So, but I think that's a great advance. And the other very important advance is what we now call pre-exposure prophylaxis. If you want to be a naughty boy tonight, and you want to make sure you don't get HIV, we now know if you take a pill, and you take a pill tomorrow and the next day, then HIV is not a problem. This is pre-exposure prophylaxis, and in this country you could obtain those tablets for the cost of a packet of cigarettes, so people can protect themselves against HIV. These, I think, are the really, there are many other important developments. I admire what the generic companies are doing, some of the combination pills, relatively cheap, some of the newer medicines very free of side effects, so people can live normal, healthy lives. So I think that all scientists in the field, any field, have to be careful that the quality of their data is appropriate, particularly when patients are going to worry and get stressed about these things, which are HIV is a very public issue in much of the developed world, where many of the community know as much or more than the doctors about these diseases. So I think what I was trying to say to this morning was to put it in perspective and say the data that these comorbidities are much commoner in HIV itself is very poor. The data that HIV affects a group of people who have many comorbidities is very strong. So in the UK, about 40% of all HIV positive people smoke compared with 10% of the population. 50% of them are very poor compared with the general population and therefore eat bad food. People who get HIV, unlike you who will take a pill tonight before they go out, are risk takers. That's how they get HIV. They're more likely to be alcoholics. So there are a whole range of reasons why their lifespan will be shorter, where they may have cardiovascular disease, where they may dement and have a number of comorbidities. The evidence that in a well-treated HIV patient who is undetectable, that he will develop cardiovascular disease more frequently, dementia more frequently, will prematurely age, I think is non-existent. As you know, as you saw me there, I hesitated a bit around cancer. And the reason I hesitated around cancer, I think there is good evidence that a number of other viruses, which are themselves sexually transmitted often, will lead to cancer. And HIV people are more likely to have such viruses. So Kaposi's sarcoma-associated virus will lead to a variety of lymphomas and a variety of skin cancers. This is commoner in HIV. A lot of the lymphomas themselves are related to viruses which are probably acquired, at least in part, by sexual activity, and so again these cancers are commoner. HPV is a good example, anal cancer, very strongly associated with HPV, which is commoner in people who've acquired HIV through unprotected intercourse, and so they get HPV as well. So the cancer argument is a more difficult one. But I was saying this morning that I think it is wrong to say, when the evidence is very poor, that all HIV patients are going to dement, for example. There is no evidence that's true. There is good evidence, of course, that untreated HIV patients at the end of their disease lifespan dement. But people who are not demented today and take antivirals, I think there is no data they will ever dement. What is the data is that if they don't take their pills, they will die, and they will infect their loved ones. They take the pills, they will not die, and they won't infect anybody else. That's the message.